Hello class, this is the infection PowerPoint. We're going to talk about inflammation, the immune system, just some basics, labs and diagnostic tests so that you know that your patient has an infection or inflammation, different types of hypersensitivity reactions and how we will treat them as nurses, anaphylaxis, what can cause anaphylaxis, and the treatment. Infectious processes like MRSA, C. diff, and other multi-drug resistant organisms. SIRS and sepsis, we're going to touch on this. You guys will build a lot more on this when you guys get to semester 9. And then we need to review a little bit of 5th semester PPE and different precautions and what diseases you would use them for. So let's go. Here's the objective that I just read. Let's go to the organization of the immune system. So you guys need to be familiar with where your cells are made. And for those of you that didn't know, it is the bone marrow, all of your cells. You can see in this picture, we've got platelets, we've got our eosinophils that are a huge player in our inflammation. We've got neutrophils that are going to fight our bacteria. We'll talk a little more about T lymphocytes and B lymphocytes when we talk about HIV. But you guys need to understand that the bone marrow helps to meet the need for protection by destroying organisms that are invading our internal environment. So if our patient has an issue with their bone marrow, what labs will we see decrease and what labs will we see increase? This is going to be a question that you're going to need to have an answer to when we get to class, okay? So really think about what's going to increase and what's going to decrease. If our patient has a bacterial infection, are our neutrophils going to go up or down? They're going to go up, right? Because they're going to increase because they're trying to attack the bacteria. So apply that same idea to the other ones that that I discussed, and we will we'll touch on this when we talk about diagnostics, which you can see on this next slide when we get into class. So if you guys remember that last activity that we did with the obesity labs, we're going to do the same type of thing with your infection and inflammation labs. So you need to be familiar with, why is my ESR going to increase? Why is my CRP going to increase? Are my platelets going to increase or decrease if my patient has an infection? Is it even affected? If you look at your patient's mast cells, neutrophils, and eosinophils, what happens with these white blood cells? Which one starts, I guess, the journey, if you will, of when a patient gets infected? You know, is it the mast cells and then your basophils kick in and then your eosinophils? Is it your mast cells and then it's like, oh, hey, this is a bacteria and neutrophils take over? So I just want you guys to understand that concept. And then I'll have a couple activities for us in class. See, there it is, lab game, and we'll be doing that in class. So just be familiar. Like I said, you don't have to memorize them, but just understand the basic concepts of why is my patient going to have an increase or a decrease of some of those labs that I mentioned. So what is inflammation? What is the inflammatory response in your patient? Well, it's pretty simple. What happens is, and I kind of talked about this a little bit in class when we talked about inflammation, when we talked about the different inflammatory diseases and autoimmune diseases, but let's just talk about it real quick. So if your body gets injured, so there's a tissue injury, and you can see where the needle is pricking this patient's skin right here. Bacteria is introduced, it sends off these chemical signals that will reduce, like your histamine. So your histamine gets released. Then what's going to happen is we get some dilation and the increased leakiness where you can see that we've got the swelling because of that. Then we get all of these phagocytes to the area, and phagocytes are going to help to kill whatever is in that area to protect our to consume the bacteria, but also to help kill whatever is in that area. So in this case, your phagocytes with your macrophages and your neutrophils are going to get rid of the bacteria and the cell debris, and then our tissue will heal. Now that's in a normal working body, right? So the signs that you're always going to see: pain, heat, redness, swelling, and loss of function. These are your 5 cardinal manifestations of inflammation. Why does your body do this? To protect you against invading organisms. So let's take a look at this next picture. Oh, I thought you guys had a picture. I'm sorry. We'll move on to, oh, well, shoot. Okay, sorry. The one I'm looking at is a little different, but we'll go with this. Okay, so causes of inflammation. So I want you to name 2 causes of inflammation and give an example of each. And how do you know your patient has an infection, and how do you know your patient has inflammation? So I want you guys to think about that question. We just talked about inflammation on the last slide. You have pain, redness, warmth, swelling, and decreased function. What are you going to have that's different in infection? Right, you guys are going to look at the drainage. You're going to look at labs, right? How do you know your patient has an infection? We're going to have an increase in white blood cells. Depending upon the type of infection is going to depend upon which blood cells be increased. Oh, there's the picture. That's what I was looking for. So which one's infected? The one on the left or the one on the right? Yeah, obviously the one on the right, I don't even know what it is. I just Googled an infected wound, and I think we can all say that that looks like a very angry wound. It looks red, it looks hot, it looks like it is going to have purulent drainage already, but it looks like if you put a little bit of pressure, more would come out. It's got the crater dimpling going on. I would say we need IV antibiotics, probably maybe even an IND, depending upon how deep it goes, if you look at the bottom one there. And then on the left, what is that one? That's inflammation, right? And what do you guys think that that could potentially be based on what we talked about this week? Gout, right? On that metatarsal joint, it looks red, it looks unhappy, and I bet our patient's going to tell us that they have like a 10 out of 10 pain. What do you guys need to do to help that patient? Yes, opioids, right? And maybe the guy on the right too might need some opioids on top of his antibiotics, depending upon how bad the pain is for that one. It's localized though, right? It's just not systemic, just like the one on the top left. That one's localized too, but we know that their pain is still 10 out of 10 because if it is gout, those uric crystals feel like glass inside their foot. All right, so let's move on to talking about different types of immunity. So what is immunity? What is passive immunity? Passive means that the antibodies are introduced from another person or animal. So think about it. How do we get passive immunity? It's from a person or an animal. So we're not talking about vaccines, right? Correct. Passive immunity is like breast milk or placenta. So we get passive immunity through our parents when we're children, little babies, right? Now, active immunity is going to occur when the production of antibodies by the immune system responds to the presence of an antigen. And that can include the flu vaccine, varicella vaccine. Any vaccine is actually giving you the antibody it is an antigen, and your body is going to create the antibodies to fight that disease or that problem, right? Okay, so we're talking about the different types of hypersensitivity. This one says, if your patient is having an asthma attack, what type of hypersensitivity reaction is this? If your patient is having an asthma attack, that is going to be an immediate reaction to an antigen, to a trigger, to something. So triggers for your asthma attack can be allergies, right? So the type 1, and this is a type 1 or IgE mediated antibodies are created, where it releases antibodies against an antigen, resulting in your mast cells to release the histamine and inflammatory mediators. This is also where your eosinophils are going to be playing a huge role, because these are going to be allergies or anaphylaxis, like allergic rhinitis or asthma as your examples, okay? So now let's go on to the next one. If your patient is showing signs and symptoms of a blood transfusion reaction, what type of hypersensitivity reaction is this? Okay, yes, that's type 2, right? So there's your IgG or IgM antibodies, or a cytotoxic reaction. This is the most common in patients that take drug takes a drug and gets drug-induced like lupus, which is a type of autoimmune reaction, myasthenia gravis, due to the autoantibodies that are going to bind to specific receptors in the body, usually like skeletal muscle, and they will have like weakness in the arms and legs and difficulty with speech and chewing, the drooping eyelid. And then the other one that you will see with this is the blood transfusion. So they must have compatible blood for the patients. If you give the wrong blood to a patient, they are going to have a cytotoxic reaction or a type 2 hypersensitivity reaction. Your other one that you will see that you guys are going to learn a little more about is the RH factor. So RH factor with baby and mom. For those of you that aren't familiar with that, I have a great slide coming up that we can discuss a little more. Let's see. It's a little further into the thing, but let me try to explain it. So if the dad is RH positive, and the mom is an RH negative mom, and she's carrying her first RH positive fetus, then those RH antigens from the developing fetus can enter the mother's blood during delivery. In response to those fetal RH antigens, the mother is then going to end up producing the anti-RH antibodies. If the woman becomes pregnant with another RH positive fetus, her anti-RH antibodies will cross the placenta and damage the fetal red blood cells. So once again, the only way you get the antibodies is by getting the antigen first. So if your patient has been introduced to it once already, like in the case I just shared, where mom had one RH positive baby, then that means the second time if it happens, there's a much higher likelihood that they can have an allergic reaction to it. So let's move on and talk about these other ones, and then we'll get into more detail a couple slides later about RH factor and blood transfusions. Just so you guys have some more familiarity, because when you get to semester 7, you'll be talking about transfusions and blood transfusions. Okay, so number 3, if your patient is complaining of morning stiffness with pain in their joints, what type of hypersensitivity reaction is this? Okay, well, what does it sound like? Rheumatoid arthritis, very good, yes. So type 3 is going to be immune complexes. So this is going to be an abnormal immune response due to the accumulation of immune complexes, or your antibody-antigen reactions. This occurs in the skin, the joints, and the vessels, which then we know leads to the inflammation and the increase in the white blood cells. You can have serum sickness, lupus, and rheumatoid arthritis are 3 great examples for type 3. Generally, we treat these with NSAIDs, corticosteroids, and antihistamines, but you guys already knew that because you know how to treat lupus and rheumatoid arthritis. Let's talk about the 4th one. If your patient is complaining of itchy red bumps after scraping their arm across poison ivy, what type of hypersensitivity reaction is this? So this is going to be type 4, and this is contact dermatitis. Very simple, right, guys? It's just a rash. It's not mediated by your antibodies, but by your cells. So when you come into contact with an antigen or a diagnostic test, when you guys get tested for allergies, they do this, and you have a reaction, like your TB skin test, right? If you get the reaction to it, this is a type 4. The only way to treat contact dermatitis is to stay away from the allergens, which kind of makes sense, right? So don't go near something that you know you're allergic to. And remember, this is just the skin. So type 5, last one, if your patient is complaining of Graves' disease, this is a type 5 hypersensitivity reaction. This is where the antibodies that are produced, they have a purpose of stimulating specific cell targets. And Graves is the best example for this. You don't have to worry about it. It's just that it ends up, the antibodies end up stimulating the thyroid stimulating hormone receptor, which creates an overactivity. So for type 5, we need to treat the symptoms. So real quickly, type 1, allergies, anaphylaxis. We're going to treat these with antihistamines and epinephrine and different, well, yeah, we'll say antihistamines and epinephrine. Type 2, this is going to be your cytotoxic reaction, like your blood transfusions, your RH sensitization. We're going to treat these with immunosuppressants for the, and then RH factor, we're going to make sure that we have, we give them the RH, they have an RH factor. You guys, for those of you that are pregnant, probably know, but they have a shot that you can take. And then to produce the reason that the myasthenia gravis is the other type 2, and for that one, we're going to use immunosuppressants. Type 3 is going to be those immune complexes like your rheumatoid arthritis and your lupus, and we use NSAIDs, corticosteroids, and antihistamines. Type 4, remember, you just stay away from it. It's contact dermatitis or like your TB skin test. Type 5 is Graves, and we're going to treat the symptoms of whatever the specific stimulated cell targets are affecting. This is kind of a nice picture. Oops, second. Um, we're going to do a types of reactions game in class, so just be familiar with the 5 that we talked about, and I'll put up a slide in class, and we'll go through the different reactions to make sure you guys are familiar with what they are and how we treat them. Okay, so this is the next part. We are going to talk about if your patient has allergies and what your patient needs to know about allergies. So this one's pretty good to think about if you have your own allergies, or you have a kid that has allergies, or you know someone's kid who has allergies that maybe your kids are friends with. You guys need to make sure that your patients are educated on how to be prepared to live safely with allergies, because it is possible, right? So wear a medical alert bracelet. You can see I put a bunch of different ones up there. Make sure that they have the EpiPen that's not expired, so they need to check the date on their EpiPens. They need to make sure that they store their EpiPen kit properly. That's just like with any medication, right? It needs to be in a nice, cool, dry place. You can see the little bag that they keep it in there. And then we need to make sure that they know that other people in the patient's life know that they have this allergy. So they need to know about the kit, and they need to know how to use the pen. Heaven forbid they need to use it, right? Okay, let's move on. So you guys need to understand that when a person is having allergies, that when they are out in the real world and not in the hospital, if it's an active food allergy reaction, that they need to use their EpiPen. You can see here it says for any of the following severe symptoms, lung, heart, throat, mouth, skin, gut, other, that you immediately go to inject the Epi, and then you call 911 and request the ambulance with Epi. Do not depend on your antihistamines, because you don't know that they're actually going to continue working, because you don't know how bad that reaction is going to be. For mild symptoms, if you have more than one mild symptom, it says grab the Epi. So we need to make sure our patients know when they are supposed to use their epinephrine, how they're supposed to use it, and when to call 911. Obviously, when in doubt, they need to give the Epi and call 911. So let's talk about anaphylaxis in the body. So you can see I have some great pictures up here. Your anaphylactic reaction starts with your antigen. It goes into the B cell. The B cell travels into that plasma cell. Then you see these little guys over here. These are the IgEs. And I told you guys in the beginning that a type 1 was an IgE-mediated hypersensitivity response. Those guys are going to attach to that mast cell. And then you see your little histamine guys are attached to it. That's what's going to happen in the anaphylactic reaction. So if that's what's happening in the body, what must happen before the patient can go into anaphylaxis? And the answer I am looking for here is that the patient has to have been previously sensitized to the antigen. So think back to the few minutes ago when I was talking about how mom had to be Rh positive before she can have that allergy. A child has to have peanut butter before they have an allergic or anaphylactic reaction to it, because the body has to build up those antibodies to it. Okay, So we need to understand that this happens within minutes of exposure. We need to say, oh, so what are the 3 physical manifestations that will occur during this? Well, you can see here, this guy looks like he's having trouble breathing. So airway constriction, or also stridor, right? You guys remember what that is? And after the chemical mediators, your histamine is reacted or activated, your smooth muscle contraction is going to constrict the airway. We're going to have vasodilation, so you can see this blood pressure over on the right, and increased permeability, so that's going to add to low blood pressure and a weak pulse, and you can see low blood pressure, weak pulse, 40, nasal stuffiness, and bronchial secretions. This is all going to occur within minutes of exposure if somebody's having an anaphylactic reaction. What labs would you expect to be elevated in this patient? So those eosinophils, because we said those are what you're going to see with allergies, your white blood cells, your neutrophils, if it's a bacterial thing, your mast cells, platelets, ESR, anything that has to do with your inflammation, they're all going to increase because the body is reacting to that chemical mediator. What is the nurse's main priority when a patient is having this type of reaction? And you can see my little gentleman over here on the right, he's saying to stop the offending agent, which means you stop whatever is causing that reaction in the body. If it's a drug, we stop the drug, right? The patient is having anaphylaxis due to food, we take the food away. It's pretty straightforward, right? So we stop the offending agent. Now, this is a sad picture because this person is clearly having periorbital edema. But what is your patient going to feel when they begin to show signs of anaphylaxis? The first thing that should come to mind is a sense of uneasiness, impending doom, and apprehension. They know something's about to happen, but they aren't going to be able to do something about it, or they have a fear that they're not going to be able to do anything about it. They can get the rhinorrhea, which we talked about earlier. They can get hives, angioedema of the eyes, lips, or tongue, the swelling. They can be at risk for a lot of different things. So we need to make sure that your patients are, they know what signs to look for and they know what to do when they have these signs. Different things that can cause anaphylaxis are insect stings, medications, or food allergies. Remember, it's a rapid onset. Your patient's going to get that stridor or bronchial constriction. They're going to get that vasodilation, so they're going to have a dropped blood pressure. They're going to get loss of consciousness. They can get tingling and swelling in the face, throat, and tongue, feelings of apprehension. All right, let's look at a few more. And then, you have this cute little picture here. So different causes, 6 different things you can be allergic to. So let's talk about it. Foods, medications, insect stings like bees, wasps, hornets, fire ants, a latex allergy, and some of the things that foods that are at risk for latex allergy is avocados, kiwis, bananas, animal serum, tetanus, snake venom, and rabies. You can have an atopic reaction like hay fever, urticaria, or bronchial asthma. What questions do we ask our patients to determine that they have allergies? When do we ask this question? So what if your patient was going to get a flu vaccine? What specific question do we need to ask about allergies? Allergy to eggs, right? Because that is a contraindication for the flu allergy. Very good. All right, so let's talk about treatment. After assessing your patient is having an allergic reaction, what is our next step? Yes, stop the offending agent. The agent is an IV infusion. We need to stop it, change the tubing, and hang normal saline. And we need to make sure that we put in a new IV, right, guys? If you need to call a rapid response, that's going to get the doctor there faster. We need to get the labs drawn so that we know what's going on. Our goals are to maintain adequate airway and ventilation, restore adequate circulation, and we need our patient to be able to verbalize the actions to prevent a reoccurrence before they leave. If they're having this in the hospital, it's very possible that it could occur out in the real world for them, and they really need to make sure that they understand how to prevent it. ABCs, airway, breathing, circulation, oxygen in high concentrations. Get that head of the bed up if possible. Maintain a patent airway. If we can't, we may have to intubate or put a trach in. IV fluids, get the fluids going. We have a low blood pressure, right? Another thing that we use is epinephrine. That's a huge one that we'll use. We can give them diphenhydramine. We can give them some hydrocortisone. They can get dexamethasone, prednisone. Are these all sounding familiar? These are corticosteroids, right? They're going to decrease that inflammation. We want to make sure that we understand that epi is not always available, okay? Epi is not always going to be right at your fingertips. So if you have epi available and you've assessed your patient and it's appropriate, then go for it. But if your patient is, if we can give some Benadryl, then we need to do Benadryl first, right? So the 5 things that we've already talked about, a lot of different things that can keep your patient safe, right? Oxygen, head of the bed up, ABCs, maintain a patent airway, give them IV fluids, give them epinephrine like a vasoconstrictor. We need to watch for fluid overload in these patients. We need to make sure that if they have angioedema or urticaria, you can give them diphenhydramine or antihistamines. Just depends upon the severity of your patient. So we need to make sure that we know how to assess our patients for anaphylaxis. And I have a fun little case study that we'll do next week. So let's touch a little bit on blood transfusions. You guys don't have to know all of this. I just want you guys to be familiar so that when you guys get to 7th semester, you understand what they're talking about. So what happens when there is a blood transfusion? Well, we have special autoantibodies that are against our own cells, and this produces that immune complex and destroys itself. So we have the hemolytic anemia with the Rh factor, and we have the pregnant mom who is Rh negative with Rh positive baby. If your patient is having a hemolytic reaction in the blood transfusions, you're going to see headache, chest pain, doom feelings. Once again, it's a hypersensitivity reaction like anaphylaxis, high heart rate, high respiratory rate. We've got to stop that transfusion immediately. Treatment, discontinue the offending blood product. Do not flush the line. We can also use plasmapheresis or an antihistamine. Once again, it just depends upon how bad the sensitivity is. So here's that picture I was talking about. You guys can kind of look at this yourself because I talked a lot about the Rh factor already. Just the biggest thing to get from this is that your patient has to have the antigens before an issue occurs with that Rh factor, okay? So a first-time mother is not going to have that problem. But a second-time mother, they could if they had the Rh positive father and they are an Rh negative mother. So just remember that, okay? All right, here's a question. Patient has angioedema of the lower face. What will the nurse assess first? Sorry. Hopefully you guys said airway patency, right? Because angioedema of the lower face is going to include the mouth, can rapidly lead to laryngeal edema and obstruct the airway. ABCs in emergencies, and airway is always going to come first, right? So this is just reviewing of the standard and isolation precautions, you guys. You should be familiar with standard precautions. That's just hand hygiene. Isolation precautions depends on what disease we're trying to protect our patients and ourselves against, which is contact, droplet, and airborne. And then we have our neutropenic precautions or our protective precautions, which are for like our immunosuppressed patients. And we need to make sure that we monitor our white blood cells with our neutropenic precautions. So we will review PPE at the very end of this lecture. Let's talk about MRSA. Everybody's heard of it. Everybody's familiar with it. But MRSA has killed, let's just put it this way. There were 100,000 deaths attributed to antimicrobial resistance in 2019. 100,000 people have died, you guys, because of things like as simple sounding as MRSA. You guys hear about it all the time, but we don't realize how many people it's actually killing. Okay, this is a gram-positive Staph aureus group of bacteria. Generally, it will colonize in the nares, and it is swollen, painful. You can have a red bump, fever if it becomes systemic. Starts off very unassuming, if you will. Okay, it's like a painful red bump. Most people aren't going to automatically assume it's MRSA. If you get a fever, then chances are that we have definitely gone systemic, and you can have something like MRSA, which stands for methicillin-resistant Staphylococcus aureus. When we get into pharmacology and we talk about our antibiotics, you're going to understand that there's only certain antibiotics that they can use because it's resistant to the Staph aureus. It's methicillin-resistant bacteria, so we can't use any antibiotics that have methicillin in it. So treat MRSA at home, we can use Bactrim and doxycycline, and the hospital will use IV antibiotics like vancomycin or linezolid. For PPE, for MRSA, what do you think it is? It is contact, yes. So we need to make sure that we use contact precautions, which is gowns and gloves. Now, environmental cleaning, what does that mean to you? If my patient is a contact patient, do I have to clean with bleach? Can I clean with do I have to use special cleaning tools for MRSA? No. Can I share my stethoscope from a MRSA room to another room? No, right? So you have to have your special tools. Anything that's in that room has to stay in that room, and they should not be spread to other rooms. Otherwise, the patient in the other room could have a chance of getting MRSA. Guys, I just realized I don't have a lot of pictures in this PowerPoint, so I apologize. I hope you're not reading it. I hope you're filling out your papers and looking in your book at the same time, because, man, this is a boring PowerPoint. I apologize. We're about halfway through, a little more than halfway through, so you guys hang in there with me. So other multi-drug resistant organisms, how does a nurse know a disease is an MDRO? Well, there's a lot of things that can cause it, so let me name a couple different ways that we get MDROs. High risk after surgery, central lines, ventilation, prior hospitalizations, prolonged hospitalizations, being in the ICU and being in nursing homes are just a few different ways that we can get MDROs. And that's because we give too many antibiotics. And if we give too many antibiotics, then those bacteria become used to it. Some different types that you guys may not be as familiar with. There's Acinetobacter baumannii and vancomycin-resistant enterococcus. So if our patient has vancomycin-resistant enterococcus, VRE, that means we can't use vanco to kill it, and vanco is like our big drug. So just understand that the more antibiotics that we prescribe, if a patient doesn't need them, the more superbugs we get out there. And then the more superbugs that we have, the less stuff we have to kill them. You have to use for MDROs, it's still contact precaution, gown, gloves, alcohol-based hand sanitizer. We already talked about it, but MDROs are usually treated with our big guns. And then we definitely get that culture so that we know specifically what type of MDRO it is so that the doctors can order the right antibiotics for our patient. Let's talk about one that Ed is familiar with. So C. diff is going to develop during the course of antibiotics. And C. diff is an MDRO. MDRO is that big umbrella. C. diff, VRE, MRSA, and Acinetobacter baumannii. These are all going to fit under that giant umbrella. Okay, so C. diff is going to look, and you guys probably already know this, but watery diarrhea 10 to 15 times a day. It has a very distinct smell, abdominal cramping and pain, which can be very severe, leaving your patients dehydrated, loss of appetite, and weight loss because they don't want to eat it so bad. They can have a swollen abdomen, and they will, of course, have an increased white blood cell count. The difference between C. diff and VRE as far as how we treat them, we need to make sure that we use hand soap, and water. We cannot use alcohol-based hand sanitizer. C. diff will not die. We must clean everything with bleach for C. diff, and then we have to use soap and water for our own hands. This is the one where if you leave a C. diff room, you need to go to the sink and make sure you wash your hands. Soap and water. C. diff is the other one that you guys have probably heard, that people will get a like a stool transplant. So there's stool in a pill, and they will take the pill, and then they'll get better. C. diff we give Vanco for. Sometimes patients end up having to go home on the PO Vanco. Generally, if your patients have these signs and symptoms and they tell you that they've been on a different antibiotic for a while, then we know that it's generally C. diff. You have to send a stool sample down, and it has to be liquid. Most labs will not accept a stool sample if it is not liquid. So if your patient comes in and they have C. diff and you're trying to rule out that their C. diff is gone, if your patient doesn't have liquid C. diff or your stool, then you can't prove to the lab that your patient doesn't have C. diff anymore, which can be a little stressful for nurses on the floor because we're like, I don't need contact anymore. They don't have C. diff anymore. So those are some different ways that we treat C. diff. We just give them stronger antibiotics and wait until they don't have liquid diarrhea anymore. So I want you guys to understand that this travels really easy, and it's not just C. diff. This is MDROs, and you can see here where in the doctor's office he goes to get his antibiotics, which put him at risk for C. diff. Then he goes to the hospital because he broke his leg, and then the healthcare worker actually spread C. diff to him after forgetting to wear gloves when he was treating a C. diff patient in another room. Then he goes to the rehab facility, and now everybody there gets C. diff. Then he goes back to the hospital, and he tests positive for C. diff, and he started on those specific antibiotics to treat it. We need to wear gloves, and we need to use our contact precautions, you guys. You don't know where the C. diff is in the room, and you don't know how easy it is for other patients to catch it. So we need to be responsible healthcare providers and protect our patients, our current patients, and all the other patients in the hospital from getting that disease. Yay, SIRS and sepsis. Okay, guys, this stuff is fun. All right. You guys, I think, are really going to enjoy this when you guys get into ninth semester because you guys get much more in depth with the multi-organ failure and stuff, but we're going to just touch on it for you guys so you have a good understanding of it. And there are questions on the exam, so I'm not wasting your time, I promise. All right, so what is SIRS? SIRS stands for Systemic Inflammatory Response Syndrome. Okay, this is where the infection travels throughout the body, through the blood, damaging multiple organs, and that can lead to death. This is the one thing that kills patients, and we need to be good nurses and catch it quickly. So you need to know your SIRS criteria, okay? The temperature greater than 100.4 or less than 95, respiratory rate greater than 20, or PaCO2 less than 32, heart rate, or I'm sorry, heart rate greater than 90, white blood cell greater than 12,000 or less than 4,000. These are your SIRS criteria, okay? Your people that are greatest risk, the elderly, the very young, people with multiple comorbidities, or people that have immunosuppression. But you guys already knew that, right? This is a great YouTube video. I highly recommend that you watch it. It's just a little bit about sepsis, and it helps you guys to understand the importance of it. So how do you know your patient has sepsis? Well, you assess your patient's vital signs in labs. So here's your SIRS criteria. Any two of these indicates that there is a potential for an inflammatory response going on. And if there is an inflammatory response going on, it doesn't mean that we're in sepsis yet. But if we find a microbial source with two of the SIRS criteria, then we are considered septic. Now, what is a microbial source? A bacterial infection, a UTI, your patient has MRSA, okay? Any sort of fungal bacterial, viral, any sort of source that we, obviously we would test for it, but that indicates that your patient has sepsis. So we need to make sure as nurses that we follow up on this. If you go and check your labs in the morning and you see that your patient has 2 SIRS or 3 SIRS criteria, maybe they have a white blood cell of 14,000 and their heart rate's like 101 and their reps are like 22, you're like, oh, this isn't good. This meets my SIRS criteria. If you have a sepsis bundle at your hospital, which normally they do, and all a bundle is that someone had recognized that sepsis was a problem, so they put together a process that you follow, then you actually should receive sepsis alerts indicating, hey, we just got this lab back. You have a microbial source. You are septic. And you can see in this picture that 16% mortality just for sepsis alone, okay? That's sad, you guys. We really need to get better about catching this before it kills our patients. So, what if your patient has a UTI, their heart rate is 110, their blood pressure is 92/70, their respiratory rate is 22, and their temp is 101? I'll say it one more time, and I want you guys to look at all of the information on your paper. UTI, heart rate 110, blood pressure 92/70, respiratory rate 22, temp is 101. What does your patient have? Yes, severe sepsis. So if you looked at your red box, you will see severe sepsis is sepsis with one organ system dysfunction like hypotension, altered mental status, acidosis, oliguria, ARDS, etc. So that means that our patient has a microbial source, UTI. They have the two SIRS criteria. And I said I gave you a blood pressure that was hypotensive. That's a 20% mortality for that. When your patients reach sepsis, severe sepsis, your patient with severe sepsis that's hypotensive with 2 SIRS criteria and their microbial source is leading down the road to end up with septic shock and MODS. And MODS stands for multiple organ dysfunction syndrome, which means one organ system is requiring interventional homeostasis. This means that it is completely shut down. Generally, those are like your kidneys. Usually you'll see those go first, okay? Let's look at what we do. How do we know that our patient is unresponsive to fluid resuscitation? Patient's blood pressure is 92/70, and I give them a 500 milliliter bolus, and then their blood pressure is 90/68. Are we having trouble? I hope everybody nodded their head and said yes. Absolutely, we are having trouble, okay? So the doctor may order like 30 milliliters per kilogram of normal saline, and let's say your patient weighs 140 pounds. You have to determine the amount that you would give based on that, that calculation, right? So it would be 140 divided by 2.2, which is going to be 64, times 30, which is going to give us 1920. So 1,920 milliliters to be able to resuscitate this patient appropriately. Things to think about. What is the normal urine output? How do you know your patient isn't responding to fluid resuscitation? Do they have output? Are your patients going to have output if they're hypotensive? Fluid resuscitation is necessary. They have to have that in order to get their body to continue working, right? So these are things I want you guys to be able to understand. Once again, it's just the basics. It's nothing crazy. But you need to understand this so that when you guys get to ninth semester, you're like, oh yeah, I remember that a little bit, and then you can build on it. You just septic shock. That's 69% of patients will die from that. 69% of patients that end up with septic shock die. So we really need to make sure we're serious about SIRS criteria and understanding that when we have sepsis, we need to stay on top of it and we need to act fast. Right? So what type of PPE will you use for different disease processes? Patient's been admitted for a newly diagnosed TB will be placed on which transmission-based precaution? Oh no, we don't know this. You guys always know TB, right? Airborne precaution. All right, so let's name that precaution. All right, I'm gonna give you guys a second. Pertussis. Droplet, yes. Shingles. Airborne, yes. Scabies. Contact, yes. AIDS. Standard. And I will do another PowerPoint for you guys on AIDS, don't worry. Mumps is droplet. Pneumonia, standard, but you can reduce exposure to droplets and wear a mask and goggles if you want. And generally, pneumonia is not the big case, right? Flu, we have to wear because that one is droplet. MRSA, contact, yes, we talked about that. And of course, TB, airborne, yes, very good. So here you guys can see that we have the disease-specific isolation recommendations. So it's just a chart. You don't have to know all of them. Please do not freak out. Review the ones that I just went over. Make sure you understand who gets what precaution. And then you also need to understand, what do we use for droplet? What do we use for contact? What do we use for airborne? And what do we use for standard? This picture over here for protective precautions is a reminder. For those of you that don't remember, if you do, don't stress about studying it. You already know. All right, that is it for Adult Health 1 infections. And the next PowerPoint that I do will be on HIV. I hope you guys had fun. And like I said, I'm so sorry I didn't have more pictures, but the activities in class are pretty cool. So I hope you guys enjoy those. I'll see you in class.